Hello, everyone. I welcome all of you to the third session of the Eastern Mediterranean Climate and Health Responder course. My name is Parvez Iqbal, and I'm a professor of University of Management and Technology, Lahore, Pakistan. It is indeed my privilege to be the moderator of this session. You can see the first slide. The title of the course has already I've shared with you. And today we are in the session 3, and that session deals with the heat-related illness and mortality. Next slide, please. Well, in this slide, you can see that there is simultaneous interpretation available in Arabic. All you need is to click the button, which is shown, which is encircled in this picture. And on the right, you can see that for English caption, click on the CC button on the bottom of the Zoom window. This course has French captioning. Please click on the link in the chat to access that one. Next slide, please. Well, this is the course schedule, 11-session course, which we are running every Wednesday except March the 18th. And today we are into the session 3. On March 4, we will have 4th session on food and security and nutrition. March 11 will be on water security. On March 25th, we'll be talking about floods, waterborne diseases, and other health issues. On April 1, session 7 will be on vector-borne diseases and climate change. Session 8 will be climate change, health, migration, and refugee nexus. Session 9 will be climate change and mental health. April 22nd, we'll have the session 10, which is building climate resilient and sustainable health systems. And session 11 will be on advancing climate justice through climate change communication, engagement, and advocacy. Next slide, please. Well, these are the session learning objectives, and there are 8. Identify current and projected changes to temperature and risks of extreme heat events in Eastern Mediterranean. The next learning objective is to compare temperature patterns and heat intensity in the Eastern Mediterranean with other regions. The third one is identify populations which are vulnerable to heat exposure. The fourth one is the heat-sensitive health conditions with examples of ways in which heat impacts the pathophysiology of the cardiovascular, renal, respiratory, neurologic, and maternal diseases and pregnancy outcomes. Fifth one is the define chronic exposure to heat, identify population at risk. Sixth one is explore strategies that health professionals can implement to safeguard vulnerable populations. Assess the effectiveness of interventions such as green spaces, cooling centers, and risk communications in protecting vulnerable population. Explore the role of the heat early warning systems and other measures in preventing negative health outcomes. Next one, please. Regarding the session logistics, 90-minute session. And in this session, we are going to have one full lecture, and this will be followed by 2 case studies. And at the end of these presentations, we'll have a question-answer session in which you will be able to ask questions, and these questions will be answered by our worthy speakers. Next one, please. Attendance is automatically recorded during the Zoom session. Your individual attendance is only counted if you join using your personal Zoom link. Your attendance is not counted if you join with a colleague's link. YouTube viewers will not count towards attendance. However, exception is for the Iranian participants only. Next one, please. Those who are attending this course, they will be eligible to receive a certificate of participation if they attend 7 or more live Zoom sessions and pass the final exam with a score of more than 70% at the end of the course. And this certificate will be a certificate of participation in climate and health from GCCHE. The final exam must be completed using the same email address which you are
امتحان
using to
النهائي
attend
يجب
through Zoom sessions. The exam link will be sent on the final day of the class via email, WhatsApp, and will close on May the 4th, 2026 at 12, almost 12 p.m. Cairo time. Format will be 20 multiple choice questions, which will be of true false nature, and participants should be prepared to take the exam in one sitting. Next one, please. This is the email Tango Responded course, and this is the WhatsApp group for updates. Next one, please. We have 3 presenters in this session. The first one is Dr. Barak Al-Ahmed. The next one is Dr. Alia Muhammad, and the third speaker is Dr. Shiba Ratnabai. It's my privilege to introduce our first speaker. And our speaker is Dr. Barak Al-Ahmed. Barak Al-Ahmed is a physician scientist at the Department of Environmental Health at Harvard T.H. Chan School of Public Health and Kuwait Ministry of Health. He holds a medical degree from the University of Liverpool, master's in public health from Johns Hopkins, and a doctorate in population health sciences from Harvard School of Public Health. Dr. Al-Ahmed studied climate change and health in the Middle East, specifically the adverse impacts of extreme temperatures on vulnerable populations like migrant workers in Kuwait. His work has been highlighted by professional health organizations, including WHO and the American Heart Association, and media outlets, including BBC, CNN, New York Times, The Guardian, and among others. In 1925, American Association for Advancement of Science, AAAS, Board Council honored Dr. Al-Ahmed with the AAAS Early Career Award for Public Engagement with Science, recognizing his outstanding contribution to engaging with the general public about effects of heat on the migrant workforce in Kuwait. So you can see that he is an accomplished scientist at a very young age. So it is my privilege to invite Dr. Barak Al-Ahmed to kindly go ahead with his lecture so that we could all benefit to his lucid presentation.
Thank you so much, Parvez. I am very happy to join you all, and thank you for this opportunity to present. As Parvez just said, I am the Director of Occupational Health and Climate Change at the Harvard T.H. Chan School of Public Health. But I'm originally also from Kuwait, and for all those that are celebrating Ramadan Mubarak to all of you. And if you're fasting and you want to break your fast during my talk, don't let me torture you. Please go ahead and and break your own fast. So today we're going to talk about the heat related illnesses and mortality. Overall, what can we do about this? What does the science tell us, and what's the epidemiological studies? And finally, I will end with some positive note on what we know right now as effective solutions for very vulnerable populations in the Eastern Mediterranean and other places. So you've all known by now that the temperatures are increasing right now. If you look at 2024 and you compare this to pre-industrial times, you'll see there is about 1.3, 1.28 degrees Celsius increase that we have already noticed. That is the number that is always quoted in the media. But what I want you to really pay attention to is not only this change in the mean, because we've got two things that are happening right now because of climate change when we talk about temperatures. First, there is the shift in the mean. You see this here, this distribution of temperatures, that change here to the right, this is what we call a push for 1 or 2 or 3 degrees Celsius. Okay, so that's what people start talking about when they discuss a climate change accord or the Paris Accord of 1.5 or 2 degrees Celsius average change. So that's just the change of the mean. What happens as well with climate change is that the curve is also being pushed down. And that creates more frequencies for days that are more hot and even days that are actually colder than what we used to see. So that is the increase in the variance. The overall, what we see is the push to more frequencies in these hot areas in the tails, and then also push to the right. So you will see more places that will have more record hot weather. And this is really important because when we discuss countries in the Middle East and in the Eastern Mediterranean region, we're already here. We're already at the tail of what's hot. So when it's pushed and then even further higher variance, then we will be seeing more record hot temperatures. That's why it's really important to see this. But I did some collection of what's out there in the literature about the Middle East in particular, and the literature does not really provide a nice picture to look at. You know, the choice of language also some of these papers have shown, and you can go and look at them. But one paper said this that climate change in this region will have important consequences for human health and society. Another paper said that human habitability or human survivability could be questioned in the future. And this is because of the increases in temperatures that are extremely high that is affecting us. But the question that we always go back and forth in trying to understand, what is hot? What can we consider as a place that is actually hot? So one way of looking at this is to take the 99th percentile. The 99th percentile means if you take all the temperatures in any given location and you look at this 1%, the highest 1% of temperatures, this is could be considered extreme heat. But others would say, well, why don't you look at the 95th percentile, just the 5% hottest days, or the 90th percentile, which would mean the 10% hottest days. Well, there are no correct way of looking at this. But if you take the 99th percentile, and even with that, you compare it to different countries, and in here we show this in one analysis that we did. So for Kuwait, which is where I'm from, 99th percentile is about 42 degrees Celsius. In Finland, the 99th percentile is 22 degrees Celsius. So, and that would be considered extremely hot depending on where you are. Which takes me to this statement that I adopted from the report that was published by the US government here in the US. Is if you think of it, a 45 degrees Celsius in Beirut, for example, will have very different implications for health than a 45 degrees Celsius in Riyadh. So why do we say that? Well, Riyadh is very much used to temperatures above 40, 42, 43, even 45 degrees Celsius. But if this hits Beirut, this will have, although it has the same number, it will have different implications. Also, I mean, think of it in the same way when you compare a very hot day, like a 30 degrees Celsius in Vermont, in the US, versus Texas. The same example applies, or just depending on time of the year. Well, did it hit when we're just still in April, May, or is it in the height of August? So why does it really matter? Why does it have different implications? Why do we see more people dying from extreme heat when the temperatures reach 45 degree or 40 degree in Spain, but we don't see the same deaths when it is 40 degrees in Kuwait? Now, there are three main reasons why we see that. Well, first, infrastructure. I will compare Kuwait to Spain for you here. Well, we have air conditioning in Kuwait everywhere. The urban design is put in a way that there is insulation from the heat outside, whereas in Spain, maybe that's not the case. But also the behavior. So people have different clothing choices, they have different activity levels, the way that they go out or not go out is also different. And finally, there is some biological and physiological acclimatization. This means that our bodies start to recognize and get used to extreme temperatures with time if you're exposed to them for a longer period. So the infrastructure is different. The behavior is different. The physiology could take some time and also become different. So because of these three things, then not the same temperature will have an impact everywhere else. So there will be places that will reach 30 degrees Celsius, but that will be extremely devastating for them. And 30 degrees Celsius in places like Saudi Arabia or Qatar or Kuwait or even Cairo would be just like a normal day. So that keep this in mind as you go through. The other thing is the heat wave. What do we mean by a wave, a heat wave that is hitting? So there are three main combination of things that are added together in it for us to determine something as a heat wave. And the first of them is actually the temperature metric itself. So if temperature, are we looking at the average temperature, the minimum or maximum temperature? And then the threshold. So that threshold is what I told you about is 90, 92, 95, 97, 99, depending on what you choose. And most importantly, for heat to become a heat wave is to have a duration. So there are examples here. For example, let's take this. If there are 4 consecutive days in which the temperature at a given location exceeded the 95th percentile, then that would be considered a heat wave. But how do we choose? Do we choose 2? Do we choose 3, 4? Actually, in the literature, there is no consensus. There is no consensus for what defines a heat wave. So still people are defining it in different ways, but you get the idea. So now we know what's hot in a certain place. It depends on the certain circumstances and certain infrastructure in that given place and what they're used to. But what about human exposure to extreme heat? Well, first, there are environmental factors that determine this. So it's not only just the temperature, it's the temperature, the humidity, the wind speed or the air movement. So think of this as if there is no air movement outside and it's really humid as well, so you feel a bit muggy. And there's radiant heat, which is sunlight, so your exposure to sunlight. So the combination of these four things will determine your exposure. But then there are other things. For example, for workers, we also look at their clothing. So what are you wearing? Are you just wearing short sleeves or are you a firefighter? You have these vapor barrier coveralls that cover you from top to bottom. There's also a metabolic work rate. So for workers that are working outdoors, if they are just sitting versus they're just picking and shovel work, really heavy workload they're doing, they're also generating internal heat. So that generation of heat, in addition to the outside exposure, then amplifies what they're feeling or the heat stress. And there's also acclimatization. Is this your first day being exposed to extreme heat, or have you been doing this for many, many other days? And then there are individual factors. So there is age. We know that getting older, your efficiency of cooling yourself might also get affected. There's comorbidities. Do you have other diseases? Are you taking medications? There's social vulnerability. So there are a number of factors that could determine an individual's exposure to extreme heat or what could be considered toxic. So I'll take here medications. We don't have a lot of evidence out there, but this is a list of certain medications. I pulled this from the US Army in 2003. You can see it looks really old as well, but we still haven't fully looked at this and updated this list. For example, let's take diuretics. If you are taking diuretics, this will result in salt depletion, dehydration that could affect ability to control heat. So let's move to what health outcomes then now. that can affect you. The first thing that you look at anywhere when you look at the effects of heat is heat stroke. So heat stroke is when your core body temperature raises to a level that your body and your organs cannot actually cool itself, and you fry your organs. But heat stroke is actually not commonly recorded. And this is a very common problem that I want you to be very aware of. If you take all death certificates, there would be something that is called the underlying or primary cause of death. That is the cause of death, or the condition that led to a train of event that then led to the death. It is rarely documented as heat stroke. So, and although these codes are available, so there is a code for heat stroke, it's T67 in the ICD-10 codes by the WHO. These are for classifications of diseases. But what we notice is that there is this chronic underestimation. And it could be because doctors don't do a really good job in documenting this. That's one way of looking at it. But actually, we know now that heat can exacerbate existing conditions. So heat becomes a contributing factor. It doesn't have to kill you through heat stroke, but if someone has heart disease and then you're exposed to extreme heat, then that could exacerbate the existing condition. So you will still die from heart disease. It will be documented as heart disease. Nowhere in the death certificate, it will say heat. But that didn't mean that heat actually triggered this. And this is really key and important to know, because don't only look for heat stroke, although it can happen, but it's rarely documented when you look at death certificates. So for heart diseases, we know that there is an impact on your heart. There is also an impact on your sympathetic activation, and that could lead to ischemic heart disease, or could lead even to stroke. This is a study that we actually did. We were really interested in this, that heat is a contributing factor to heart disease. So we collected data from 27 countries. We collected 32 million deaths from heart disease. And what we wanted to look at in this really large data set from 27 countries, is probably the largest database ever assembled on environmental exposures and heart disease, is to look at the impact of heat on heart disease. So dying from causes because of your cardiovascular system. So what we noticed here, you see this is all-cause cardiovascular disease. Here you see ischemic heart disease, which is heart attacks or stroke or heart failure or arrhythmia. And now you see here on the x-axis is the temperature percentile. So this is how much the increase that you'll see in a temperature given any location, because we pulled from different locations and they have different temperatures. And here's the relative risk of dying. And you will see that around the 90, anything above the 90, there is an escalation here, an increase in the risk of dying from heart disease when you're exposed to extreme temperatures. Also, the same thing that we notice with cold. So put together, we calculated that for every 1,000 ischemic heart disease deaths, there is about 2 that are attributed to extreme heat. So 2 in 1,000, you might think, well, 2 in 1,000, that's not a lot. But actually, heart disease is the leading cause of death globally. These numbers can quickly add up. But if you look at cold, not heat, so we looked at heat, there's 2.3 deaths for every 1,000. It's actually 9 deaths per 1,000. That's more than double the amount. In fact, I will show you this. This is a data set from Barcelona in Spain. And what it shows is that although when you look at the relative risk on a very, very hot day in Barcelona, it will have about 2 or 2.5 times the risk. That's 250% increase in the risk. But if you look at the contribution of how many deaths actually were from heat and how many deaths were from cold, you will see that it's 9 to 1. There's about 567 deaths from cold and only 29 deaths from heat. So many people would look at this and say, well, heat is not that important. Well, let me show you the next graph. This is how many days were in each of these temperature. Turned out that this day, that was so devastating, there was about 200% higher risk of dying in Barcelona, happened only once. So when we have more days of extreme heat, then it is very likely that we're going to see even more contribution of heat deaths than it is for cold deaths. And that's a very common issue because we know now, because of climate change, these bubbles here are going to increase. They're going to increase in size. And because of the high risk, that means there will be more heat deaths that will accumulate. Overall, there is many studies that looked at the net deaths because of heat, and that is also increasing with time. So we will see that there is an increase in death that will not be offsetted by the decrease in cold. So overall, we have been advocating to use all-cause mortality if you want to see the actual burden of heat on mortality in different countries. The problem with heat stroke is that it's rare and it's underreported, and that people actually during a heat wave, they might not die from heat stroke, but they might die from other conditions. So the problem that is very common in epidemiology is data in regions that need it the most. So if you look here, you will see that in many places where there is epidemiological gaps, actually are the places where environmental exposures at extreme magnitude and it could get worse. So no data, no problem? Absolutely not. There is a big problem and we need to get data from regions that actually need it the most. So that's heart disease. Next that I want to talk to you about is kidneys. And when you're exposed to extreme temperatures and exposed to extreme heat, what happens is three things. First, there's dehydration. Second, there is salt that you lose with it. And then number three, if you're doing any physical work, there is low-grade muscular injury. The three of them put together will have a direct insult on kidneys. And what we've noticed over the past few years is that there are clusters of chronic kidney failure among young men. And these young men are, it's very common that, and we see it in Mesoamerica, some places like Guatemala, Honduras, Nicaragua, Costa Rica. What we see there is that these young men, they otherwise healthy, they work really in very extreme hot conditions, and that results over time with repetitive insults to their kidneys, and then they end up with chronic kidney disease. It is very common in these sugarcane farms. And it has been investigated for many years now. And this is one of the work that was done by La Isla Network, which I will touch upon at the end of my talk. But it's happening elsewhere. It's happening in different places. This worker is a Nepali worker that worked in the Gulf countries and is on dialysis right now. His age is 38 years old. And Aaron Baker here wrote a very nice cover that I always show and talk about, is that chronic kidney disease actually could become the black lung of climate change. And we should always keep an eye on it. Here in Kuwait, we also started to see the same patterns because we see the non-Kuwaitis, these are the migrant workers that work outdoors. There is an increase in the risk of acute kidney failure compared to the Kuwaitis, which and also think about the infrastructure and what's available and what's not, that you can shield yourself from extreme heat, that we did not see an association for the Kuwaitis, but we did for the non-Kuwaitis. So my next slides will talk to you about the cognitive function decline. So we talked about heart disease, we talked about kidneys. The next important thing is your ability to concentrate when it's extremely hot. This is an experiment that was done in the US in a campus that we've got 24 students, college students, that were just randomly allocated to a building, an accommodation that had air conditioner. And then another 20 that did not have an air conditioner. It was just completely by random assignment. And then what the researchers did is that they gave them these tests. For example, two-digit add and subtract. So 57 minus 14, and then you do it on your phone. They did it during July of 2016. And then they calculate how fast did it take you to answer, and they will compare to those that were in the AC building versus those that were not in the AC building. And the results are fascinating. They showed that students that are actually living in non-air conditioners are actually experiencing significant decrements in their cognitive test performance. You see, there's separation of those that were in air-conditioned housing versus not. So these are students, but what about workers? Well, there is accumulating evidence now that shows that there is increased risk of accidents, there is increased risk of injuries, your ability to make judgments. Think of construction workers having to do hand-eye coordination or doing some very specific task on scaffolding, and at the same time, they're exposed to extreme temperatures. That clouds your judgment, that affects you. This is a meta-analysis that looked at 24 studies from 6 different countries, and what they saw is a 17% injury during a heat wave day versus non-heat wave day. These are all accidents and injuries that just happen. And there are workers, the male workers, usually in agriculture or in construction, that are most affected by this, but others are. This is my last part that I want to talk to you. I've been talking all about problems that we see, how heat can affect your heart, your kidney, your ability to concentrate, increases the chances of having accidents and injuries. But there are effective solutions. I want to bring to your attention the work that has been done by La Isla Network in Nicaragua, what they call the Adelante Initiative. In 2017, they did a memorandum of understanding between La Isla Network, which is a group of researchers and a nonprofit organization that works directly with the sugar mills, these sugar farms that are in Nicaragua, and also the producers of the sugarcane and others that are related in these stakeholders in Nicaragua. What then they did is that they worked with the community and they implemented interventions. And the interventions were pretty simple. We're not talking rocket science here. It's breaks, shade, hydration, and good hygiene. And I say good hygiene because we need restrooms that are close to the farms, for example, or a construction site, because we see that there are people, workers, that they don't want to hydrate because they don't want to, there is no restroom that is nearby, especially also important for women and sanitation. So with that in mind, when they applied these 4 interventions, they did something really fascinating. They measured everything. They measured the workers' heart rates, internal core body temperature, skin temperature, metabolic rate, hydration, and they put cameras everywhere. They measured people's exposure to overall heat, which is, for scientists, this is absolutely amazing what you need to do. And then now with that, you can see the impact of these interventions. So here are the results. It's really fascinating. Look at this. Here on the left, you will see this is a workplace that had no improvement, no interventions, just business as usual. And that's their core body temperature. If it reaches 38 degrees Celsius, that's your core body temperature, not the outside temperature, that means you're at higher risk. And this is determined by WHO and many others. And what you see, the only drop that happens here is at 1 p.m., or just before 1 p.m. It's actually at 12. And why is that? It's the lunch break. So the workers only core body temperature drops when there is lunch break. So here's what La Isla Network did. So they started to introduce 1, 2, 3, 4, 5, 6 breaks. And what they did is that these short intervals or breaks kept the core body temperature just below the 38 degrees Celsius all the time. This is from when they started working at 6 a.m. all the way to around 1 p.m. But look at this. This is hospitalization for acute kidney injury. Now, this is harvest 1, so that's before the interventions. This is harvest 2 when they started to apply, and then this is the third harvest after 3 years of applying the interventions. And look at the hospitalization for acute kidney injury. Among those that work really very high workload is or most at risk, used to be about 10% or 9.4% of workers that actually develop acute kidney injury. This dropped to just 0.6%, less than 1% of workers now after the interventions. In fact, for those that do medium and low workload, is almost near elimination. So this work has been published now. But I know what you're saying. You're saying 1, 2, 3, 4, 5, 6 breaks. That's a lot of time. And employers don't like this. Employers want you to be working. They want their workers to keep working. And you would say, well, 6 breaks, that surely would affect the workers' productivity. But wait until you see this. So, in these sugar farms in Nicaragua, there is the most objective way of measuring productivity is actually come the end of the day. Because whatever you collected, they put it on a scale and they measure your productivity. So I have an exact amount objective of productivity of these piece rate workers. And look at this. So here is from 2012 until 2022, right? So the first 3 years, this is data from the mills, and the workers were just working 8 hours a day. Okay. And this is how much they produced. So went from 8 hours a day here when the intervention started to happen. So this was reduced with the breaks to 6, 5, and now almost stabilized at 4.7 hours per day of working. So that's a reduction from 8 to 4.7. But look at this, how much that was produced per worker across time over the years. So it went from 0.8 tons per day to actually 1.57. That's a double of the productivity. So although they work less, they are producing more. And if you think of it, this is just if you're going to the gym or you're working doing a hit training or something. If you take a rest break and you come back sharper, you come back with more concentration and able to perform better. And this is now shown and captured in really good, decent data that shows us this how much increase in productivity, although the workers are working less hours. So overall, there was a 60% return on investment because of this, and because right now you've got lower staff turnover, reduced absenteeism, reduced accidents, reduced hospital care, all of these things add up. So within 3 years, you've got for every dollar that you invested in these interventions, you're getting 60 cents on the dollar. That's also an economic return. So overall, if you look at the data and what interventions did, this is work from La Isla Network, there was 23% less work, but that was associated with more than 90% reduction in occupational kidney injury and between 9 to 19% increase in productivity because the workers now are more able to perform better with these rest breaks, and about 60% return on investment. For the industry, actually, it's also great because you increase productivity. It's a win-win situation for everyone. And that's one thing that needs to be highlighted as an example that needs to be extrapolated to other industries as well. And in public health, and you probably know about this by now, in occupational health and in public health, we seek to eliminate diseases. So that's why we're in this business. We're not here to treat someone who just showed up with heart disease, because that's not public health. If you're really good at this, you'll be a great heart surgeon or whatever, but that will not mean that you need to work on prevention, because you have to work on prevention. And this is what we do. We do this with vaccines, we do this with occupational diseases, and we know ways in which we can eliminate certain occupational diseases, and hopefully we can do this for occupational kidney injury. So here's my take-home messages for you in this lecture. Heat is a global public health concern, and there is epidemiological evidence that shows detrimental impact on your heart, on kidneys, and brain health. And I've shown evidence on these three. Now, the available science would actually send some warning signs about the future of outdoor work, and especially in regions and groups that are most vulnerable. And in those, unfortunately, we have least data. But the good thing that I want you to leave with is that there is evidence in support of effective practical solutions, like the work that was done by La Isla Network in Nicaragua. So I want to stop here and thank you very much for your time.
Thank you, Barak, for this excellent presentation. Dear participants, Dr. Barak, please wait for the question answers if there are any towards the end of the session. So in the meantime, I would like to invite our next speaker. Next speaker is Dr. Alia Muhammad. Dr. Alia, I'll take this opportunity to share with the accomplishments of Dr. Alia Muhammad. Dr. Alia Muhammad is a public health officer with WHO in Iraq, leading to health promotion and climate change and health portfolios. Uh, she provides technical leadership on the integration of social and environmental determinants of health into national policies and programs and coordinates Iraq's National Health Adaptation Plan and climate health initiatives in alignment with the global WHO frameworks. Her work focuses on advancing climate resilient and equity oriented health systems, strengthening community engagement and risk communication, and supporting national capacity to address emerging public health threats. So, with this, let me invite Dr. Alia Muhammad to kindly share her slides and come forward and make presentation.
Good evening, everyone. Can you see my camera?
Yes.
Okay, perfect. Let me share my slides. Okay, perfect. So, good evening, good morning, everyone. This is Dr. Alia Muhammad, the Public Health Officer at WHO Iraq, responsible on multiple agendas, but one of them is the environmental health with focus on climate change and health. Very happy to be with you and thank you for the invitation. I would take you in the next 15 minutes to WHO efforts in Iraq to tackle the climate and health agenda. So just to give you a bit of context on what we're working on and the context of Iraq and climate change, Iraq is among the most heat-exposed countries globally, with increased frequency of the days with above 32 degrees centigrade, and it's one of the most vulnerable countries to climate change, with extreme summer temperatures exceeding 50, and in southern region it even reaches 60 degrees centigrade, and it affects the habitat, the productivity, and of course the energy security. Currently, we have over 150 days exceeding 35 degrees centigrade. Severe water stress, of course, unfortunately, and with the focus on Tigris and Euphrates basin, declining in river flows, reduce in rainfalls, increase in evaporation due to increasing temperatures. The upstream pressures have resulted in a chronic water scarcity, salinization with the focus, of course, in the southern region, and deterioration of water quality, especially in Basra, and as I said, in the southern governorates. Desertification, it's a major problem. Over 90% of Iraq land is risked with desertification. And dust and sandstorms are a major as well risk. Usually in the 90s, we had 25 days per year. We call them dusty days. Unfortunately, now we've reached over 200 dusty days a year. And our projections with the Ministry of Health and Ministry of Environment, we're projecting through our modeling that we will reach almost 300 dusty days a year by 2050. Climate shocks reduce the agricultural productivity, threatening food security and driving climate-related, of course, displacement. Many people are being displaced. Now we have over 150,000 climate migrants who are moving from different areas in the southern region due to climate change. Most of them are farmers. Heat is no longer an environmental issue, and this is what we've been advocating and what we've been seeing in Iraq, and it's becoming a public health emergency. What we did, first of all, we said that we need to set the scene. Climate change is affecting hardly Iraq in different sectors, including health. So we started advocating for the climate and health agenda on the table of discussion, not only on a public health aspect, but even with the government. And this is what we've done through establishing climate, of course, with the support supporting Ministry of Health of establishing a climate change section in Ministry of Health in the Public Health Directory. And this section focuses on dealing with all the agendas, climate change and health. And this was a very big, honestly, achievement for Ministry of Health. Usually, Ministry of Health works within Ministry of Health, and we don't have that massive intersectoral coordination among different sectors. And this is what we've been pushing, of having different coordination bodies for climate change, whether with the environment, with the water, agriculture, and on other departments that will eventually affect the public health in general. We've integrated a full chapter of health into the NCDs, which is very important, and this advocates or pushes the climate agenda into the national policies and discussion. Globally, we've supported Iraq to engage in the ATTACH, which is the Alliance for Transformative Action, Climate Change and Health. And we've been working hardly and successfully. A few months back, we were able to have a dedicated technical working group within the One Health Committee. So as you know, the One Health is an approach. They have multi-sector, including the agriculture, environment, and health. The three stakeholders do different decisions, and we call this platform or approach the One Health approach. And we did the higher committee of One Health, and underneath we have different technical working groups, and we were able to have a fully dedicated technical working group for climate change. And this is very important to push the climate and health agenda, as well as advanced early warning and climate-informed surveillance. We started on this, and we look forward in 2026 to continue this work. Now, the real work, the hard work, was actually conducting the VNA, which is the Vulnerability and Adaptation Assessment, and the HNAP, which is the Health National Adaptation Plan. Not too many countries in the region have done this, so we are very proud that we were able to do this. The Vulnerability and Adaptation Assessment is a huge document, almost 300 pages. We've done different modelings to reach to different climatic hazards, and I think in the next slides we can see the details. We did a mapping across different exposure, sensitivity, and adaptation capacity within the VNA, and we were able to identify 5 diseases mostly impacted by climate change, and the heat was a massive indicator, or I would say a root cause for these diseases. The first was respiratory disease, which is due to dust, sandstorm, and the heat temperature. The cardiovascular disease due to of course, increasing in temperatures, hemorrhagic fever, with the focus, of course, on Crimean Congo hemorrhagic fever, and the mental health, depression, suicide were also highlighted due to increased temperatures. And we've seen that there is an increase in the peak of this during summer. Also quantified health system resilience gaps were introduced in the VNA. Okay, HNAP. Based on the VNA, we were able to do the HNAP, which is a Health National Adaptation Plan. So each country has an adaptation plan, and there are different sectors. So we were able to conduct the Health National Adaptation Plan. We have different projects, but the focus was on making the health system more adaptable to different climatic hazards. And of course, the dust, sandstorms, and the heat or increasing temperatures were the main focus for the adaptation plan. I cannot go through the details because it's a very detailed plan, but I'm just trying to tell you how we tackled this issue. Of course, risk communication and community engagement were our one of our main interventions. We were able to do an institutionalization for the RCCE with the national emergencies plans and the climate health framework in general. And we were able to bring different entities on board, whether the religious shrines, the tribal communities, the host communities, the migrant communities, youth, medical students, different governmental sectors and NGOs on board to do an RCCE task force to tackle different issues related to climate change in the mostly affected areas. And of course, building capacities for different youth and volunteers on different protective behaviors, especially during summer and increased temperatures. Again, we wanted to go beyond this to have a bigger umbrella based on WHO, and we've done the community protection strategy, which is an umbrella for different, I would say the SBC, social behavioral change, the RCCE, and the health literacy and health promotion. The main focus was to mobilize communities to take responsibility for their own health and have the enough capacity to do so. And I'll discuss this moving forward. This is some of the documents that we were able to generate in the last 3 years. Basra, why Basra? Basra is a southern governorate in Iraq, highly impacted by climate change. So we worked with a focus on Basra adaptation plan. We worked on a generic adaptation plan for the whole country that includes 19 governorates. We wanted to understand what's going on with the migrant communities. So we did a CAP assessment, a very interesting CAP assessment on the impact of climate change on migrants in Basra. And then the 2 documents, which is the HNAP and the VNA. In the pipeline, we have other documents related to climate change with a focus on heat. Now, how did we do it with the VNA? We did different equations or modeling, but we've assessed 4 dimensions for the vulnerability. So we don't just take the morbidities and mortalities, but we need to do modeling with different sectors, right? So we brought up different climatic exposures. We brought the different, not only the temperature, the water turbidity, the salinity of water, different things, or climatic, I would say, indicators. In addition, we brought different environmental sensitivity indicators like water quality, water access, desertification. And we brought also the socioeconomic vulnerabilities like the poverty, the displacement, the wash gaps, whether in the healthcare facilities or other facilities, like schools, for example, or houses. Also, we brought up the health system vulnerabilities. So not only the morbidities and mortalities, but we also need to discuss and see the workforce shortage, which will come to the HR or the infrastructure deficits that we have, especially that Iraq went through different wars and sanctions, so the infrastructure is not the best. So now we're putting another burden on it, which is the climate change. So we brought these different dimensions and we did modeling to see to what extent we have vulnerabilities and what are the mostly vulnerable countries, governorates to climate change. So this is quick. We have hundreds of, honestly, maps, but this is one of the interesting maps that indicates the highest climatic exposure or the most climatic vulnerable governorates in Iraq. And we can see that the Basra is the highest. And then we have Najaf, Al-Anbar, and Salah ad-Din. We've seen that there is different, of course, you would say why Basra, and then in the middle, Anbar or Salah ad-Din. Those governorates were highly impacted by ISIS. So the war and all the security issues impacted the infrastructure, and accordingly, they are not very adaptable to the climate change, for example, while Basra, increasing in heat temperature, affected this. So each governorate had its own story behind it, but these are the most vulnerable governorates to climate change in Iraq. Of course, we've the projection of course of the RCP scenarios, and you will tell me what's RCP. RCP is the representative constraint pathway, which is, I would say, the forecasting. So we do forecasting for the climate change impact and the temperature increase. And in the RCP, we have different scenarios. This is the best scenario, and this is the global mitigation. So it's not only Iraq mitigation, but the global mitigation. In case we did great, what's our situation? And here, if we've done nothing, if we stayed where we are today, this is the situation. The red color is extremely impacted by the increase in temperature, and to the point that maybe in some areas in Basra and southern Iraq, people will not be able to live in these cities or governorates. The implication, of course, eventually the health will have all the implications of these pathways. So of course, more frequent and prolonged extreme heat events, higher risk of heat strokes and cardiovascular mortalities, an increased burden of heat facilities, and greater vulnerability, especially in the fragile or vulnerable provinces. From the VNA, we've seen that there is a significant asthma increase, cardiovascular decrease, cholera when it comes to waterborne disease, Crimean Congo hemorrhagic fever, and mental health. Mortalities showed a direct correlation with high temperature days, with the humidity, increasing dust, and of course, heat was always acting as a multiplier factor for different NCD burdens. Now, Dr. Barkol talked about the hidden burden of heat mortality, and I think this is a very interesting point. So it's not only the direct impact, but the hidden one. The heat strokes under-recorded. This is a major issue that we have, and now we've been discussing, and I think the information management team today from WHO Iraq is also participating in this. We've been discussing with the Ministry of Health how to improve the heat stroke registration. The misclassification of the cardiac arrest is also a big issue. No standardization of the ICD heat coding in the emergencies, and the surveillance, unfortunately, is still not climatic sensitive, and this is a big issue and one of the projects that we want to work on moving forward with the government of Iraq. Okay, we've done the VNA, we understood what's the situation. This is just a quick glance. The HNAP, what are we going to do? We want to strengthen the PHC, and we're working now on a model of care, which is the package, the service package for the primary health care. And we want to do the service of package or the model of care that is provided in the primary health care to be climatic sensitive. So when someone approaches the primary health care, and this is a doctor or physician to see him, he needs to be aware about different climatic sensitive or the indicators that it is the PHC is climatic, it has a climatic sensitivity or environmental friendly PHC from A to Z, from the diagnose until different things related to even in the infrastructure of the healthcare facility. Digital health and surveillance integration is something major. The early warning systems, and we're trying to work, and this needs a huge governance that we're trying to work on among different sectors in Iraq and even in the region. So we're working in close collaboration with Kuwait, Saudi Arabia, and Iran to see what is possible to do in the early warning system. Workforce training is essential. Continue working on community engagement and awareness. And we have 26 projects in the HNAP, but this is in general the main things that are related to heat-related illness. How much do we need? We need approximately minimum 2.6 billion to 22 billion. That's not a huge number, by the way, because it covers the infrastructure. And in Iraq, we have more or less 3,000 healthcare facilities, PHC resilience, surveillance, and workforce. Lessons from Iraq, I think it's very important to quantify vulnerabilities before designing any intervention. We need to integrate climate into PHC reform. I think it's the time, especially in the region, to have a more climatic lens when we want to do any reform for the primary health care. Mapping resilience geographically is very important, and try to link the health adaptation plan or any climatic health interventions into the NCD strategies. The NCD strategies, by the way, for those who doesn't know, it's the national determined contributions. So it's very important to link it and trying to put the priority for the vulnerable populations. Okay. Moving forward, we want to work on different areas, and this is for 2026 plan, strengthening the climate-sensitive disease and syndromatic surveillance, including the migrants and displaced communities, establishing community-based surveillance, and this is part of the community protection. So we don't wait for the healthcare or the e-warn system to give us the warning. We can establish a community surveillance system, and this is part of what we're doing in the community protection. We want to add the climatic sensitive indicators to the e-warn and try to work on the DHIS2 as well, and expanding the e-warn system to high-risk areas, especially in the southern region. And as I said, the PHC model of care needs to be more climatic sensitive. I've been repeating different terminologies over and over because this is what I want you to take as a take-home message from my presentation. I will leave you with this photo that we as a WHO team have taken in Basra, actually, in one of our missions, and we can see The temperature here was honestly maybe 60. It was a dusty day. We can see the water scarcity, what it did to the humans and the animals and the land. By that, I will finish my presentation, and thank you very much, and over to you.
Thank you very much, Dr. Alia Muhammad, for a very insightful presentation. Now we move on to our third speaker, and she is Dr. Shiba Ratnabai. I take this opportunity to introduce our third speaker. Dr. Ratnabai works as a core clinical faculty in obstetrics and gynecology at Ras Al Khaimah Medical and Health Sciences University in United Arab Emirates. She is an experienced obstetrician and gynecologist with specialized training in reproductive medicine, and she has expertise in assisted reproductive technology procedures. As a life member of the Indian Menopausal Society, she has actively led and participated in numerous community initiatives focused on improving the health and well-being of aging women. So it's my pleasure to invite our next worthy speaker, and that is Dr. Shiba Ratnabai. Dr. Shiba, please.
Thank you. Thank you for the kind introduction, sir. Good morning, good afternoon, and good evening for all my co-learners from different parts of the world. Actually, I am basically a gynecologist and a medical educator and a very passionate ambassador of climate change and healthcare sustainability. And today, like both the previous speakers, they spoke about the impacts of climate change on a cardiovascular system, central nervous system, as well as the effects on the kidney. But I will be speaking about something which both of them did not mention, and many of us we are not even aware about that. That is the effect of extreme heat on the reproductive outcomes, both maternal as well as neonatal. So at the end of this webinar, you all will be able to describe maternal and neonatal effects of extreme heat. You'll be able to identify heat vulnerable pregnant women in the embryo region. You will be able to apply in the professional feasible heat adaptation actions, and you will be able to communicate effectively during the heat waves events. Next slide, please. So first, let us see, why does it matter in the embryo region? Because in the embryo region, because of the climate change, we have prolonged heat sessions with high humidity. We have urban heat islands as well as air pollution. We have a diverse population. We have outdoor workers, long commuters, and shared house people who stay together in cranes rooms in large numbers. And pregnancy is a climate sensitive condition. Next slide, please. Increasing heat risk days because of climate change, extreme heat days affecting pregnancy have doubled in many embryo region and countries. Climate change is increasing the exposure frequency of pregnant women to extreme heat. Heat waves are becoming more longer and more intense. Next slide. So let us see what is extreme heat. Like Dr. Barak said, sustained high daytime and nighttime temperatures and frequent heat waves. So what are heat waves? Consecutive days above seasonal norms of temperatures. We have high humidity, and this increases the effect of extreme heat, and risk rises even without direct exposure to sunlight. Next slide, please. First, we will see what is the effect of this extreme heat on the mothers, that is on the pregnant population. There will be dehydration. Dehydration will lead to reduced plasma volume, which in turn will lead to hemoconcentration and increased incidence of DVT, that is deep vein thrombosis in these kind of women. Because of heat stress, there will be increased sympathetic activity. There will be higher risk of hypertensive disorders complicating pregnancy. There can be, because of direct effects of heat, there can be heat exhaustion, syncope, preterm labor due to premature uterine contractions. Next slide, please. So this slide shows the maternal mortality rate because of extreme heat from 1990 to 2015 in different countries in the EMRO region. Next slide, please. Now let us see what is the effect of this extreme heat on the fetal as well as neonatal outcomes. Fetal means when the baby is still within the maternal uterus, and neonate is immediately after delivery. There is reduced uteroplacental perfusion because of the increased sympathetic activity, there will be peripheral vasodilatation. So blood will be going more to the peripheries. So blood supply to the maternal brain as well as blood supply to the uteroplacental blood, the bed will be reduced. So this reduced blood supply to the placenta in turn will reduce the blood supply to the baby, which can cause intrauterine growth retardation. Because of this increased parasympathetic activity, there is increased risk of preterm birth. Preterm birth rate increases 4% for each degree centigrade rise in the temperatures. And again, preterm births increases by 26% during heat waves. And there is a risk of low birth weight because of the reduced uteroplacental blood supply. Higher stillbirth rate during the extreme heat rises 13% during the extreme heat days, and 1.5% neonatal deaths in low and middle income countries are attributed to extreme heat events. And these newborns, they are vulnerable due to immature thermoregulatory system, because thermoregulatory system is not fully developed and active in the newborn. Next slide, please. So this slide shows the rate of neonatal mortality in different countries in the EMRO region. Even though total neonatal mortality, there is a decline, there is an increase in neonatal deaths due to the extreme heat events in different countries in the region, again depending on the vulnerability of the patients. Next slide, please. So who is most vulnerable? I told you not that every patient will have the same impacts during these heat waves or during the extremely hot days. So the pregnant patients who are in their third trimester of pregnancy and patients who have a history of preterm birth in the previous pregnancies, they are vulnerable, and patients suffering from hypertensive disorders complicating pregnancy, diabetes, anemia, and obesity, they are again more vulnerable. And outdoor or shift workers and people who commute for long distances to the workplace, and pregnant women who have limited access to cooling and who have crowded housing, they are again more vulnerable to the effect of extreme heat. Next slide, please. So now let us see what climate action we can do for saving the lives of mothers and children, how we will be rising to the challenge. Next slide, please. So when we talk about the EMRO region, we are talking about a very diverse group of situations. Like in the EMRO region, we have high-income urban countries and we have middle-income countries, as well as we have fragile conflict or displacement settings. When we think about the high-income urban countries, it includes Gulf, United Arab Emirates, Qatar, KSA, Bahrain, and Oman. Like these countries, even though they have the same challenge of extreme heat and heat waves, like Dr. Barak said, most of these countries, they are fully air-conditioned system. So when I look at the data of low birth rate or stillbirth or preterm labor in this region, like we will not be able to see a big difference compared to other normal regions in the world, because these patients, they are not exposed to this extreme heat. Starting from the houses to the hospitals, offices, everywhere there is a working active air conditioning system. So here in this situation, what we need is, we need heat alert systems. We should have clinical protocols how to deal with the extreme heat, and urban cooling setups, as well as occupational protection. But when we think about same countries from different countries from EMRO region, like middle income, that is mixed urban and rural, where we are going to talk about Egypt, Iran, Pakistan, Morocco, Jordan, and Iraq, they may not be able to provide the same system of air conditioning or other cooling spots for the pregnant patients. So in these setups, what we can do primary care integration about how to deal with this extreme heat, then messaging facility and the facility cooling system, as well as dashboards. But when I speak about the countries like Afghanistan, Yemen, Somalia, Sudan, Syria, Libya, and Lebanon, they are very fragile or low income countries with the conflict and displacement settings. So here definitely we may not be able to do the air conditioning or other support system for this vulnerable group of pregnant women, but at least we can do the outreach and mobile clinics. We can have community cooling corners in which these pregnant women will be able to seek they will be able to seek to rest during the extreme heat hours, and there can be simplified triage and community worker-led messaging. Next slide, please. Now let us see what are all the policy priorities. Policies are very important to bring in like streamlined measures to reduce the impacts of extreme heat on this population. Number one, include maternal and neonatal health in the health action plan. Number two, occupational protection for pregnant women. Like they may be provided that they need not work during the time of extreme heat, like say from 11 o'clock to 4 o'clock in the evening, or C-star times, or like community cooling centers, and thermal monitoring in maternity wards in the hospitals, as well as neonatal intensive care units. And we can have seasonal maternal and neonatal dashboards where there will be early warning systems in place. Next slide, please. Let us see how we are going to implement this. Like a short-term implementation roadmap includes screening and messaging to the vulnerable group of women. Medium-term, their facilities, the healthcare facilities should be adopted to deal with the extreme heat and give protection to the pregnant women. In long term, there can be urban cooling centers, as well as there can be climate resilient health systems. Next slide, please. So to deal with any climate action or climate emergency or climate disaster, we need interprofessional teams. Like when the professions, we work in silos, we are not going to attain a very good results. So there should be interprofessional collaboration to deal with the impacts of extreme heat. And when we look at the interprofessional roles, the doctors will be able to do the risk stratification. Risk stratification, in case we take the UAE, we will not be worried much because most of the patients will have access to the cooling and air conditioning system. But there may be a group of women who are working, who may be exposed to the heat. So these people are identified as high-risk people. And at the level of nurses and midwives, they will do the screening of these pregnant women, and they will do the counseling, like how to avoid their exposure during the extreme temperatures during the day. And public health systems will do the surveillance as well as dashboards. Community health workers, they will do the community messaging to alert these women of the coming extreme hot days. Next slide, please. So what are all the interprofessional clinical actions we can take as healthcare professionals? One thing, heat risk screening in the antenatal clinics. We have to see who are the patients who are very vulnerable, and again patients who have preeclampsia, gestational diabetes, and like Dr. Barak said, people who are on certain kind of drugs, they are more vulnerable to the effect of extreme heat. Then personal heat action plans, lower threshold during heat alerts, as well as we have to do the postpartum counseling. Next slide, please. So what are all the facility and system adaptations? We can include maternal and neonatal health in heat action plan, thermal monitoring in maternity and neonatal intensive care units, occupational protection for pregnant workers, and heat alert message system, especially in the middle and lower income countries. Next slide, please. So now when you look at the take-home messages, one thing, extreme heat is a preventable maternal risk factor which can be done with policies in place as well as interprofessional collaboration. Strategies must be tailored to setting the type of the framework which is different for different countries in the EMRO region. Different countries in the EMRO region illustrate different adaptation pathways. And the last but not the least is that climate adaptation means safe maternity care. Thank you. Thank you very much for your patient listening. Thank you.
Thank you very much, Dr. Shiba, for this very
Thank
fine
you.
presentation.
Thank
Please hang around here for a little while because
Mhm.
there might be a few questions on your very nice presentation.
Thank you,
So,
Prof. Thank you. Mhm.
So, dear participants, now we have about 10 minutes at our disposal, and there are certain questions. I'll go through those questions and will request the participant. Is Dr. Alia there? Dr. Alia, are you available? I think
Yes. Can you hear me?
Yes.
now I can hear you. Fine,
Perfect.
thank you. Right. While I'm going through the list of questions, I will take this opportunity to ask one question to Dr. Barak Al-Ahmad. And that question is that you mentioned that there will be 6 breaks during the day and the productivity will go up significantly. Has that model been, first of all, what is the duration of each break rather than having 6 small breaks? And the second one is that has that thing been emulated anywhere in the region by the landlords?
Very good question. So the first is these breaks were about 10 minutes in intervals. So they're short breaks that they spread throughout. Sometimes it can take longer than 10, it could be 15 or 20. Now, the problem has always been is that the industry is always very nervous. They're very nervous to apply this. They would have their doubts, and it gets dismissed many times that this is a very specific situation. But in fact, it is not. The evidence is very consistent in showing that when you give humans in general rest breaks over time, their performance actually increases. The problem in many parts of the world, in the Middle East, in the Eastern Mediterranean region, we have what's called the midday ban, which is just a ban of work from 11 a.m. or 12, depending on what country, until 3, 4 p.m. And this is from June to August. So anything within this window, you don't work. Anything outside this window, you actually work. But the evidence is not very supportive of such calendar-based interventions. The evidence actually points to risk-based assessment, depending on the actual temperature, because it could be 10 a.m. and you could have heat stroke. It could be 4 p.m. and you could still have a heat stroke. So it depends on the risk, the actual risk that could be calculated at any given workplace. But I do understand why policymakers love this midday ban because it's easy. It's easy to enforce. It's easy to penalize those who don't do it. But it is our job, actually, and I'm happy that I'm talking to people and experts here like you, Alia, and Shiba, that we and all the attendants that we have to keep pushing and advocate for better science to inform policy.
Another question is to Dr. Shiba, that you have mentioned about the cool places for the mothers. What do you do in the rural settings in places like India?
I think, sir, we can have community cooling centers where these expectant mothers, they may be, they may be able to assemble during that peak time of summer, like say maybe around 11 o'clock to 3 or 4 o'clock. And again, there can be some cooling centers which are attached to the hospitals also, sir, outpatient department, because in fact, inpatient departments definitely will be air conditioned. So community cooling centers can be arranged. Because in a country like in India, actually we see a lot of cases of low birth weight, preterm labors and stillbirths in India, especially Rajasthan and other regions, whether there is extreme heat. Even though it is more hot in UAE, I don't see intrauterine growth retarded babies or preterm labor or stillbirth because everywhere it is air conditioned. So these pregnant mothers, they are not vulnerable. It's not that in India it is more hot than UAE, but we see more number of intrauterine growth retardation, small for dead babies, preterm labor, and again stillbirths in many parts of India. In Tamil Nadu, like where I was working before, like certain months they don't allow the husband and wife to stay together. They come and take the girls to their mother's house because if the patient conceived during that time, the baby will be delivered during May or August. That is extremely hot months of the year. So the rate of neonatal deaths are more during May and June. So they don't allow the husband and wife to be together like 9 months before that. They come and take the girls to the parents' house. So that way they don't give birth during that months of May and June, and thereby they reduce the neonatal mortality. That's because the vulnerability is more, sir, because we don't have the facility for these people to have air-conditioned houses.
Thank you. Another question is to Dr. Barak, and that is that we are looking at the effects of climate change in human health workforce. What will happen when the human workforce will be replaced by robots? Is there any study being done that how their work will be affected?
I think my job will be the first to be replaced by robots. So while I have it now, maybe we can find ways. In fact, I am more concerned right now on recent expansions of what is being called the future jobs or the green jobs or the AI jobs, actually. If you see these data centers that is being built everywhere, the data centers, they don't get built by AI. They're built by humans. So for whatever that means, even in places that are extremely hot, like the Gulf countries, we're building data centers, which requires a lot of water. And we don't have water. It requires a lot of air conditioning and electricity is going to be more expensive. So I think it may have very good implications in understanding what can be done. But this conversation on automation and workers has been in the 60s and in the 50s and all the way in the past century. And it can be a distraction sometimes that all these jobs will be replaced. I think it's more like our jobs that's going to be replaced by AI than it is for the delivery driver that is going to deliver your lunch and dinner and iftar. If you're ordering iftar, that's not a good thing. You should cook. But in general, I feel that the jobs that are manual jobs, construction, picking watermelons, picking strawberries, working in farms, these are not going to be replaced. The lawyers, maybe, uh, us, academics, teachers, these are possible. And we're not exposed to extreme heat as other workers outdoors.
Another small question is to Dr. Shiba, and that is that if a country cannot establish formal community cooling centers, what low-cost alternative strategy can be used to protect these vulnerable populations during heat waves?
Shiba, you're muted.
Oh, so sorry. Thank you. Like when we are not able to, when the country is not able to provide the community cooling center, there can be other alternatives, sir. Like we can have thatched sheds with the roof made of coconut leaves, straw, that kind of things. And we can pour water over that, which keeps the temperatures down for some time, sir. There are a lot of things which can be done at home when our ancestors, they were practicing that. That time we never had the air conditioning system, but still these ladies were protected. So again, we can have like big mud pots filled with water within the house. And especially these thatched houses and sheds, they provide a lot of cooling effect. So that will, and maybe we can try the fan and other alternatives along with this.
Dr. Alia, can you comment on that one? The low-cost solutions to extreme heat waves in countries which are not very privileged? Dr. Alia, can you hear me?
Yes, I can hear you. Can you please just repeat the question, the last part?
I said that about the low-cost solutions to heat waves in countries which have scarcity of resources.
Yeah, so for example, yeah, please. Can you hear me?
So what kind of low-cost solutions, can be taken in very poor countries to protect the vulnerable population?
Yeah. So, for example, for Iraq, we've done in our community awareness sessions different mitigation measures or plans how to, for people or vulnerable populations, especially in Iraq, for example, the most vulnerable were those who migrated from different areas, from different southern areas, and settled in Basra, for example. And Basra is already a vulnerable area for climate change. So we gave different instructions, for example, from a community point of view, whether for the hydration and the ORS, which is the oral rehydration solutions, whether on the clothing and even the colors of the clothing, when to go out and how to go out. The peak hours, people need to know the peak hours. For example, one of the interesting things that and I think it's obvious, but we got it, was the traffic or the police who works during different hours. And this is one of the occupational threats due to climate change and heat waves. Most of our heat strokes comes with those who works in the street, and mainly police in southern areas. So we started working on giving them awareness or different mitigation and adaptation measures. For example, to put something on their head, the colors usually try to wear something light. And by the way, these are, it might look very simple mitigation measures, but they're really effective when it comes to people with low income or simple people, most vulnerable, who can really I would say prevent the heat, even the shadings, different shadings. We don't have for example, in Iraq, for those who put on umbrella during peak hours of heat, it looks like you're trying to be very luxurious, and people would laugh at you. But we're trying to promote different behaviors, and this comes under the social behavioral change, how to take different precautions and mitigation measures to, I would say, protect yourself from heat related illness during peak hours. So this is from a community point of view. Maybe as well from other things that we've been working on a healthcare facility is the cross ventilation. I think it's very good. The block zones that we use, whether on the windows or in different shades, and trying to avoid different heat sources during the peak hours. So different mitigation, I would say, steps that we can take, and they are almost free of charge or with a very simple cost that can really prevent a massive heat-related illness. Over to you, dear.
Thank you. Dear participants and worthy speakers, we are coming towards the end of this session. I would like to thank all the three worthy speakers for the very knowledge-intensive presentations, and the participants for being part of this session. Thus, this session has come to an end, and over to Maggie if there is any announcement. Maggie, can you hear me, please?
Thank you. Thank you so much, Parvez. That's it. Thank you so much, everyone. See you in the next session. Bye.
Bye-bye.
Bye bye. Bye.